Welcome to the Vatech monthly webinar series. I am Jim Mayer, Education Team Director.
And my name is Paul Stone. I'm the West Coast Education Specialist with Vatech. I'm located in Las Vegas, Nevada, not far from Dr. Miles, a little bit north, and really great to be here.
Yeah, today we're excited. We're going to be bringing on Dr. Dale Miles here in a little while, and he's going to be covering talking about implants, how CBCT can ensure implant success, prevent failures. Part of that discussion today, as you all know, is going to be examining and viewing common causes of failure, identifying potential pitfalls during patient assessment specifically for the implant planning, and really talking more about the importance of CBCT and the value of guide construction for reducing and eliminating these implant errors and resulting morbidity when we are doing these cases. And in addition to this series here, we have our KOL series, and coming up in April, really building off of what Dr. Miles is presenting, is going to be we're going to be bringing on Dr. Todd Engel, and we're going to do a three-part series with Dr. Engel, all about guided surgery. So in April, he's going to be presenting on single site, May multiple implants, and June full arch. So this is really, each series is going to build on each other, starting with the core one from today with Dr. Miles. So look forward to some more information on Dr. Todd Engel's April session coming up, and all that can be found on our website at vatechamerica.com. Paul, in addition to this Key Opinion Leader series, you and I are doing a Vatech series that really talks more about the Vatech platform, our devices, workflow. Tell us a little bit about that, what we call our Fast Track Friday series.
Our Fast Track Friday series, if anybody's been in attendance, these webinars we've been putting together are really designed for both doctor and staff to quickly pick up tips and tricks, touching on all parts of the Vatech imaging suite, from patient positioning to beginning software to more advanced software workflow. So for the month of March, we'll continue next Friday, March 12th, discussing intraoral sensors and that whole workflow. And then continuing the following Friday, the 19th, we'll discuss 2D and 3D imaging workflow and patient positioning from start to finish for both modalities. And then the following Friday after that, the 26th, discussing easy 3DI in detail, and specifically clinical case planning and looking at different cases. So really try to hit something every Friday this month.
Yeah, and that's for your entire office. We're trying to get everybody, doctor, clinical staff, front office, have something for everybody to understand the technology and really to be able to convey that to our patients. Right. Paul, how does this series all come up about?
Yeah, so mostly on feedback from clients. So any feedback for these or any future webinars you may want to see delivered, or any Fast Track Fridays, please email us at sales@Vatech America. We also have just on the screen our education email address for any questions for the education team, and customer support. Easy way to contact support, cs@Vatech America, and our website, and of course our social media handles @Vatech America.
Definitely. During the session, I want to make sure everybody can see our presenter and hear everything. So you should see the presenters at the top, the screen below that. And also, if you are having any audio issues, click on that help button if you're using the onboard keyboard audio, and then that should navigate you through troubleshooting that. If you continue to have issues, just go ahead and call in at that number on your GoToWebinar session, and you will be linked into the conference. Just be aware that everybody will be muted. If you do have questions, you can click on your Q&A box over off to the right, enter a question for the Vatech education team. Paul and I will be standing by, and we're going to hold all of our questions to the very end. So that will be at the very end of the session. Dr. Dale Miles, we're all going to convey and then do a Q&A session at the very end.
Right. So we will be offering 2 CE credits for today's webinar. So look for an email after the session is over with the credits.
Yeah, and that will probably be done in the following weeks in March. Those CEs will be issued to the email that you provided when you signed up. We did talk about Q&A session after the presentation, so please do stick around to the end. And this is running today from 5 Eastern to right about 7 p.m. Eastern. So a 2-hour session, a lot of information, and Dr. Miles will be sticking around to have a Q&A after our session there. I would like to introduce Dr. Dale Miles. He is a diplomat of the American Board of Oral and Maxillofacial Radiology and the Board of Oral Medicine. He's held academic positions at several dental schools. Welcome, doctor, including what? Connecticut, Indiana, Kentucky, Arizona, Texas. From Canada, correct?
Yeah, no one can pronounce it. It's called Dalhousie University, the first dental school in Canada ever. So
perfect. Well, we welcome you, and we want to thank you so much for spending this evening with us and everyone who has signed up. I think we really have an exciting presentation because everybody's getting back to the office. We just talked about, Texas is opening back up. A lot of the East Coast, West Coast, really a lot of states are opening back up. We've had a lot of offices that are really getting into dental implants, and you have really a whole suite of tools and education and knowledge for us and our attendees to really look at some cases and through your experiences of what to look for and things to look out for.
thank you. I hope I can fill that bill for you. I've seen an awful lot of implants. The unfortunate part is a lot of them were failures, and I'm not actually in on the planning. I think the failures were because some folks didn't use the appropriate imaging modality. They didn't use cone beam CT. So I actually have a talk. You'll see it at the beginning. You'll see the title, which I'll switch to today's title in a second as well. So
I'm going to make you the presenter so you can go ahead and share your screen, and
yes,
we can go ahead and get started with your presentation. So we can go ahead and see your screen there.
Okay. All righty. Oh, I put you back in front here. I want to get you reduced. So all right, well, there's my presenter screen, but let me, I'm trying to get this window reduced a little bit.
All right.
And I've got all of you guys here now. All right, well, let's just go back to the presentation. So here we have, the first slide, and what it said was the Rocky Horror Implant Show. And oops, you guys popped up again for some reason. I guess when I touched that top bar, the Rocky Horror Implant Show, and I had a whole music themed thing going on with Branamark and the people from the Rocky Horror Implant Show with the Time Warp playing, but I'm going to skip that because I got a lot of information to present in 2 hours. So we're going to talk more about how CBCT can ensure your implant success. I won't say that there won't still be the odd failure, but hopefully going through the content that I'm going to present to you, it'll help minimize your risk. It'll help you do things a little bit easier. Some of you may have returned. I hope I have a few groupies out there that came to previous webinars. I normally have that when I speak. I actually had that last weekend at 3 o'clock in the morning when I did a webinar like this for the people in South Africa. They made me get up real early. In any event, I want to show you some travels that I've done. I practiced in Toronto. I did my graduate work in San Antonio. I then went back to Canada to Dalhousie University to teach for several years. University of Connecticut as a visiting professor. Indiana as a graduate program director in diagnostic sciences, which basically was oral medicine and oral radiology. And then I got recruited to Kentucky as a chair of half the school, and then as a dean, associate dean for clinical affairs at the first school they built in Arizona. So you can see by the list, I can't keep a job, obviously. Hopefully somebody's laughing out there. So who you have in front of you, I'm a dentist first. I did that right up till 99. I did it 1 day a week in all the places I practiced or I taught, but I practiced for 7 years in my own practice just outside of Toronto before I went to graduate school. So I'm a radiologist by training. I've been a professor. I went up through all the ranks, and as you just heard, I lecture constantly across the country and around the world. I do have a disclaimer. I came up with a decision support / report software called Easy Writer. Myself and a colleague, Dr. Robert Danforth, did the expert content, and a company called Cybermed did the programming. And it's a very cool little program that I think I've actually introduced previously in these webinars. And you can see my last one. I'm a recovering academic. I shouldn't have uncovered that, but after all those places I've taught, you can see why I'm recovering. And I have no compunction to go back at this stage. I'm having too much fun doing what I'm doing. The objectives today, we're going to briefly introduce some principles because I think it's important to kind of refresh yourself on the understanding of the technology you bought or that you're about to buy or looking to own. We're going to talk under the implant and patient assessment section, which is where some of these failures occur, about some systemic conditions that will actually impact your implant case. Then I'm going to show you a whole bunch of reasons for failure, primarily because of inadequate imaging. And then we're going to answer any questions you have at the end. So there's the educator part of me. I have to tell you and give you a roadmap on where we're going. So you're dentists. Some of you may be dental specialists out there. We all were considered our own radiologists until more recently. In 1999, radiology became a specialty here in the US. It had been a specialty in Canada, where I started out since 1979. But we really only saw images in one plane of section. You can see a partial panoramic here on the left. You can see a bite wing radiograph on the right, and that is a radiograph. I scanned that in. That's why it's digital now. It was a film-based radiograph. But these are images that underestimate changes. Kind of a nice screening image for a condyle, but that's not its right orientation. And there's so many other structures around it that half the time you can't see what's going on. Also, it's not a truly lateral. The lateral pole is over here, and the medial pole is closer to the tip of the yellow arrow. And this is the pterygoid fovea, or a depression in the condyle. And I'll show you that in 3D. Some of you have seen those in 3D color images off your cone beam machines. And with the intraorals, obviously, there's limitations in size and what it can display. So these are nice images. We also see, you know, cephalometrics from the side as well. But with cone beam, now we're looking at a whole bunch of slices. And those of you who own machines, you know what I'm talking about. There are axial, sagittal, and coronal planes of section that you have to actually look at in its entirety in order not to miss anything. And we've been through in other webinars how you review your volume. So it's not a single image, but a volume of data. It's stacks of images, 300 to 500 slices in 3 planes of section. They're called TIFF images, TIFF. I won't go into that today, but this is an example of an axial image that most of you won't ever acquire because it's way up in the top of the head. We're looking from the foot end. That's why this little F is down here in the box. This tells me in the software I'm looking from the foot end. And you can see the frontal sinuses, okay? These are your eyeballs. These are the tops of the orbit area. And there's some schmutz, good East Coast term for some of my friends out there. There's some schmutz, okay, in this frontal sinus on the left. And if you have a smaller field of view machine that you're doing your endodontics and implant and other things, and you didn't want the responsibility of a big machine, I'll show you where the limitations are. This is a young child. This is probably, I can't remember the age, but basically there's some things going on in this coronal view. This is coronal view through the maxillary sinus region, okay, still in the ridge areas where you see some teeth. And you can see that there's a deviated septum. You can see that there's some schmutz again in here. This is the ethmoid air cell complex. And this complex actually goes into the lateral recess of the frontal sinus. This is actually frontal sinus. So there's a lot of stuff going on in this kid. This kid probably has, you know, rhinorrhea, postnasal drip, maybe some facial pain, maybe a headache. And if your volume, if this inflammatory change affects the osteomeatal complex, the opening from the maxillary sinus into the nasal cavity, you won't see it because your volume captures the dental bases. Some of you have machines that will capture slightly larger than that and get up to the condylar region. Well, if you did that, you would capture some of this material. But if we go back, your volume would miss everything in here. And not that you need to diagnose that, but there might be problems going on where you weren't able to see it. So if you have a larger volume, you've got more responsibility. And of course, as we told you in previous webinars, there are structures in the middle of the head that are very important that you need to learn about. So here's a large field of view volume. You can see I've got an arrow on here showing some minor change in the dens portion of vertebral body C2. And you will pick up some of these changes too. If you move your 8x8 volume back to pick up the third molar, you'll pick up airway and spinal column. But here's the change in the frontal sinus. Here's the change in the ethmoid sinus. Here's an opening into the sphenoid sinus. That change can go there as well. So this poor kid may end up with a pansinusitis, and what you were treating him for was to move his teeth around orthodontically. So if you have the volume, you need to look at the data. We can do funny and wonderful things with the data. You can assign color, transparency, and opacity to the little cubes called voxels in your volume and make these stunning images. The principles are the same no matter what size volume. You can assign color, transparency, and opacity. The image on the right is a three-dimensional condylar head with changes on the articular eminence and a loose body in the joint space. Well, you would think about this in a thin slice grayscale view. If you had a 1/10 of a millimeter slice, you might pick up a part of it here and look small, and then as you get further in, it looks bigger, a little round opacity. So and I always say this when I lecture, you CBCT owners need to learn and understand the tools in your toolbox, because you can do most of these things in the three-dimensional software that comes with your machines. So for implants, and this patient obviously doesn't need an implant, but you can see that there's a tooth that if we wanted to replace it, if tooth number 30 required an implant, you'd want to know what the character of the bone was around that, not only the quality and the amount, but also the architecture. And there's no way of actually visualizing the architecture unless you can see all three dimensions. So if you're worried about this, then you've got a right to be worried. And right off the bat, what I'd like to tell you to think about is if you're getting into implants, and I know some of you out there are already doing a lot of implants, if you're going to do the surgical piece, I would suggest you always use CBCT, and I would suggest that you probably should use a surgical guide, and we'll talk more about that as we go through. Back to the principles, we're going from grayscale 2D images that we, interpret to what we call visualization. And the visualization is extremely important. And how do you do that? Well, you do that with 3D. Now, here is a partial panoramic. This is actually reconstructed from cone beam, but it had a really nice impacted tooth number 6, or if there's any international folks out there, tooth number 1-3. They left the little rot partial in there, obviously, because here's the rot wires coming from the plastic. But for localization, this is a difficult task in 2D imaging. Okay, so 3D for implant, 3D for localization is amazing. You don't have to worry about, buccal object rule, Clark's rule, tube shift rule. All of that goes away, because what you do is you image it in 3D. And this is called a surface rendering. This is a full 3D surface rendering, but we've done it at probably about 40 millimeter slice thickness, so you can see partially into the mandible. But if you look up here, 16 is unerupted, okay, because it's impacted and it's being impeded by a developing supernumerary out here. Looks like it's just hanging on in the sulcus. So you don't have to worry about seeing that on 2D images and kind of trying to figure out where it is. You just visualized it. So this is an old case. I finally resurrected the panoramic image. This is a digital panoramic showing impacted tooth number 32 with a large cystic appearing lesion around it, no opacities, maybe some destruction of the external oblique ridge, no resorption of the teeth, but this is an odontogenic cyst or tumor, one or the other. Well, when in our lifetime did we think as dentists that we would be able to take an x-ray of a patient like this with a pacted tooth with a cyst around it and be able to see the occlusal surface anatomy? Your answer should be never. I do it frequently. Here is the same image with the cone beam CT. You can see destruction of the roots on this one. It's actually a different patient, but similar impaction. And you can see the occlusal surface. You can see the morphology of the developmental grooves in the tooth. And in some softwares, in the one I use, I have a endoscopy tool, a virtual endoscope. So this is the same image with much higher resolution, color, and much more detail in the impacted tooth itself. That turned out to be an odontogenic keratocyst, and so did that. So it was good to put the two together. So with medical CT, there's a couple differences. A big scanner, high dose, okay? But this modality captures every point of every piece of tissue in the scan that's acquired. Dental CBCT, like the one pictured here from Vatech, this will capture cubes, not every point in the scan, but cubic areas in the voxels. So they can be very, very small, and the detail will be good, but they can't separate things like connective tissue, like fat and muscle, the way you can on conventional CT or then MR. So here's what happens. This captures on a plane, and then they shift the gantry in that the patient was lying in, and they take another slice. So this takes 200 rotations and slices to get all the data, and there's dose with every rotation. Whereas cone beam just gets these small cubes of tissue in one pass. So high detail for bone, not real good for soft tissue in many cases. A little more scatter sometimes of soft tissue in these kinds of scans, but are complementary modalities really when you think of it. This is where I go to have my single malt at the end of the day, where I'll be going at 7:02 this evening, and we have lots of beautiful sunsets here in Arizona. But unlike medical CT, cone beam is faster, safer, less expensive, of course, more convenient and dentally specific. And for us, that's amazing because you can do some tremendous things. You put the patient in any scanner, you have a detector over here, the source over here, x-rays go through the patient, and they capture, in this case, as it rotates around, a cylinder of data. Okay, the patient's data is all in that cylinder. When you put it in the machine basically goes through its image processing or reprocessing of the image data, and you can get the excess stripped off and be left with soft tissue, bone, air spaces, and whatever, with tools to play with.
I'll figure it out. I'm going to use all the power of my brain.
Boy, that's loud. I hope I woke everybody up with that one. If there are any female dentists out there, this is the male brain, okay? This is Homer out there. So, okay, so we were talking pixels that are in your 2D imaging, grayscale little rectangles. Voxels are isotropic pixels. They're basically cubes, small little cubes. And they can range from 0.1 or even sub 0.1 to a half a millimeter. CT, the thinnest slice is about a millimeter. You can get a 0.5 in between in the software, but we actually get much higher detail and resolution. So very rapid going over of some of the basics. Hopefully that will trigger your thought process as to why you can use cone beam CT for some tasks, but you may need conventional CT or medical CT or even MR for other things, especially with the temporomandibular joint and seeing soft tissue of the disc with MR. So field of view is important. All images, doesn't matter if it's cone beam or conventional CT, they're reconstructed in a 1-to-1 ratio. So there's absolutely no image distortion. The measurement accuracy, it's to 0.1 millimeters. It's how much a click of a mouse is on your mouse, or how much shake is in your mouse. And the voxel attributes we already told you about. The voxel attributes are basically the color, transparency, and opacity. I'll show you an image about that. So images are 1-to-1, accuracy 1/10 of a millimeter. That makes it ideal for actual implant imaging. It makes it ideal for reconstructing a guide from the cone beam CT data and getting a surgical guide to do your placement. When you are drilling down and it says stop here on the guide, it's because of the accuracy that the guide was made with from the cone beam CT data. So in these pixels in cone beam, you can, instead of just putting grays, you can put any number of colors and any number of shades of each of those colors. So your color images are amazing when you get them. So again, here are the attributes. We color map to the pixel gray levels. So instead of this being a black, gray, and white image like a cephalometric, we can actually assign to the pixels these attributes and make these kinds of images. All right, why is that important? Well, and I'm going to show you one other tool because I'm going to talk about some systemic things that you need to actually change your image appearance in order to make yourself a better clinician and a better diagnostician. This is an image I've shown before that is a lot going on in here. This is a MIP, or a maximum intensity projection image, which they'll show you how to use in the Easy 3D dental software. But you can see tooth 11 is going northeast, tooth number 6 is going west, and there's a supernumerary. Now this is made in this fashion for showing calcifications, and I'll show you another couple screens of why that's important. But there's not a lot of information here. There's just information that you'll go, I can't do this case by myself. I need an orthodontist and an oral maxillofacial surgeon by my side doing this case. So we'll go thin slice first, and as we're scrolling through in a coronal plane, you can see that the enamel of tooth number 11 is up here. So this tooth is totally inverted as well. And there's a big follicular space around tooth number 6. So there's a lot going on. Where did that supernumerary go? Well, this is 1/10 of a millimeter slice, so we don't see it until we scroll further in. But you can send one image to both of your orthodontist and oral surgery colleagues that tells the whole story and gives them a chance to see what, how difficult the case is going to be. This is the same image. This is a full 3D color surface rendering of this region. You can see that tooth number 11 is not only inverted, it's rotated 180 degrees. This is the concavity this is the cingulum on tooth number 11. This tooth, we might be able to surgically expose and get a band on and drag it in here if there's space, but this one's not going to go in this space without a lot of effort or surgically removing it and transplanting it. And there's the supernumerary. It's up in the nose, up in the nasal cavity already. So good for the oral surgeon to know that this is a tough case. You also have a diagnostic responsibility, and this is best sort of illustrated by the following 3 little cases. Here's an 8x8 field of view cone beam machine, coronal section through the first molar regions. You can see a little bit of gray in this right maxillary sinus, a little mucosal change, end of story. Wouldn't even tell the patient about that. The next one comes in, you see a dome-shaped radiopacity here within the right maxillary sinus. That's a mucus retention cyst, antral pseudocyst, whatever you want to call it. You'll tell the patient there's some minor inflammatory change there, but it's not going to reach up and block the ostium, the opening that we told you about between the sinus and the middle meatus. So end of story again, watch that radiographically. The final patient comes in and they got a lot of mucosal change in the right sinus, but the left sinus is totally opacified. Oh, by the way, the tissue around the inferior turbinate's enlarged relative to the left side. There's some little tags over here. So there's some inflammatory change in this right nasal cavity. So this is probably a pansinusitis, or at least a chronic maxillary sinusitis with a nasal component. So it's a rhinosinusitis. And if all of this is going on here, the chances of other inflammatory change going on in the rest of the paranasal sinuses is very high. So this, you have a diagnostic responsibility, or a clinician's obligation to refer or re-image and see what the rest of the sinuses look like, the ethmoids, the sphenoid, and the frontal sinuses. So you don't have to re-image, you don't have to make the diagnosis, but you have to recognize the change and refer it properly. So here's a case. This is just by way of introduction. You want to do some implant planning for this case. You can see a big loosened area here. This happens to be below the inferior alveolar nerve canal. This is a Staffney defect, or a submandibular salivary gland depression. How do I know that? Well, with cone beam, it's real easy. All you do is do a 3D rendering. We're looking from the tongue side, and there is the anomaly, okay? It's where the salivary gland tissue has remodeled the inside, and they can take all kinds of shapes. Normally, they're below the inferior alveolar nerve canal, but they can meander into the gonial angle area. They can be above the canal as well. But how easy is it? You know, scratch your head, come up with a differential, think about biopsy or sending for biopsy, and then you go, oh, wait a minute, I remember that Staffney defect or cyst, and you go and image it with 2 clicks. This is what it looked like in the axial plane of view, okay? When I was imaging this patient, as I went further south, you could see, and this is a MIP image, by the way, because I wanted these to stand out. But when I was imaging this patient, I saw a small circular calcification, and I went, I wonder what that is. So I did an MIP image. I thickened it out to 10 millimeters, and I found 2 calcifications. And then lo and behold, when I went in the coronal plane section, I found some up in the sella region. Now, these are in the cavernous segments of the internal carotid artery. I don't expect a lot of people to know that out there, but if they're circular, if they go around the vessel, you're going to find out in the next 10 or 15 slides that this is probably a type 2 diabetic that's either undiagnosed or pre-diabetic, or they're uncontrolled. Why do we see those, or where do we see those? Well, this is where your condyle would be. So if you are doing implant and you're imaging condyle to make sure there's no arthritic problems or whatever, you look at this, or your volume captures the condylar area, the condyle would lie right about here. So you're going to see these calcifications. This is the sphenoid sinus. This is the pituitary gland. The carotid artery comes up past the condyle medially, and then comes up, bends forward, and goes up again. And I see all these calcifications all the time. So we'll go into that in a little bit. So here we are. You know, when you get these beautiful drawings, I mean, this is probably the sexiest image I've ever seen of a stylistic implant in a space for it, okay? Anyone can do an implant, right? I'm not so sure. This is stuff I took off the internet, just took some examples. Haven't even imaged all this prosthesis, so we can't see what's going on here. Here's one I've shown multiple times. I don't know why they needed, obviously somebody wanted to place as many implants as they could, but what's this one supporting, you know? What's this one supporting? What's this one supporting? Anyway, we won't go there. This is all on 6 on the top and partial on the bottom. This was the type of imaging that we used to be dependent on, panoramic and intraoral. Then some people, like the high-end ones that were on the cutting edge, would say, oh, I do CT, and I send it to Implant, and they give me back this data that I can make these accurate measurements with. You know, I put an overlay on or whatever. We've gone so far past that with these implant software programs now, and with surgical guides, we can place these almost with impunity. But I still see this kind of stuff. This was Osseo News. This was a question posed last October. I have treatment planned a patient for implants to replace 24 and 25. All right, so they're going to replace those 2 teeth. What's he worried about? If I install 2.9 diameter implants, there'll be less than 1.5 millimeters between them. Could I just install one big 3 millimeter, 3.3? What do you recommend? You know what I recommend. I recommend you go back to school, learn about, implant planning, because it's not Homer in 2D. Okay, what we're looking at is we're looking at Homer in 3D. And my suggestion, I don't go on there because I get myself in trouble because I'm quite blunt. But I recommend you get a CBCT scan, and plan it properly. All right. Now this one is a case that I'm just showing you a couple by way of introduction. 2D imaging is not, the new panoramics are really great. The digital pans, the digital intraorals are also very high resolution, contain a lot of detail, but sometimes things are not what they seem. This is a reconstructed portion of a pan. You can see a lot of the dentition looks pretty good shape. There's these 2 big, they look like big radiolucent areas, but they're quite symmetrical. What on earth is going on there? Well, it's kind of like Forrest Gump, life is like a box of chocolates. You never know what you're going to get. Even the 3D reconstruction when I did it didn't look that bad. You can see that there's some concavity here. The bone's quite thin. But if I were somebody wanting to plan implants, this guy fortunately doesn't need them, I'd want to have some very accurate data. Well, let's look in other planes of section. First of all, the gentleman had just received 3rd molar extractions, top and bottom. You can see the extraction sites for teeth 1 and 16. In the thin slice data as we're going through it, we also found a lot of inflammatory change in the right nasal cavity, so we put arrows on it and report it in our report. But here's the freaky thing. This is the axial view about midway through the mandible. The mental foramen is sitting just about here, and you can see it on this side. Well, that doesn't look normal to me. Let's go look at another plane of section. There's the bone that you have. I don't even know how anybody can function, but this guy was doing quite fine, thank you. Luckily didn't need implants, because I don't care what narrow-bodied implant you want to place, it ain't going in there, okay? Look at what he looked like. This is what the mandible looked like, and it was probably paper thin in this region. So this to me is like, OMG, let's stay away from that one. So that's what it looks like, folks, and you never know what you're going to get. So if you want to do your implant planning from, some type of single panoramic or intraorals and panoramic, don't be surprised when you palpate and whatever that things don't always come out the way you seem. Good thing he didn't need an implant. If you have the data and you can place implants, these icons, or these aren't icons, these are the actual, sort of cartoons of the threaded implants. You can place them, you can move them, you can rotate around and see that it doesn't contact the inferior alveolar nerve, or it's not going to impinge into the sinus. This is called implant planning, and you can do it pretty easily with most cone beam CT machines, and you certainly can do it with the Vatech machines and their easy 3DI implant planning. So I don't know if many of you recognize this commercial, but I'm going to show you this one first, and then I'm going to tease you a little bit, okay?
15 minutes could save you 15% or more on car insurance.
Everybody knows that.
Well, did you know Pinocchio was a bad motivational speaker?
I look around this room and I see nothing but untapped potential. You have potential. You have, oh boy.
So of course I couldn't leave it alone, guys. I'm talking about anybody can do an implant, right? I'm sorry, but not everybody can do implants. And people that want to do implants have to get sufficient training and use the sufficient tools to actually do them. So here's my version.
I look around this audience and I see all of you dentists, and I know you can do implants, and you can do implants, And you can do. Oh boy.
So I hope I didn't offend anybody out there, but some of you can't, okay? I don't mean that you can't, that you shouldn't, and you shouldn't get training to learn, but there's a lot of folks out there that think they can do it because they've got good dental and surgical skills. You need all the tools to help you do it properly and reduce your risk, reduce the morbidity, post-operatively, and to make your life happy and your patient's life happy. So at the school in Arizona, when I first came out here, the first dental school, the Arizona School of Dentistry and Oral Health, we put in a machine that would allow you to do cone beam CT when you need it. And when you make these measurements, they're as accurate as 1/10 of a millimeter. So you know that you can put an implant in here that's, probably 3.5 by 10 millimeters with impunity. And if you plan it like that and use a surgical guide, try it in before, try before you buy. You can show the patient that it's going to work out just fine. If you are planning it and you move it a little bit and oops, it's too long an implant, you can see the little red things happening there. Most of these programs will show you that you're not in a good location, so that you need to back it out or, measure different or place a different size implant. Now, a bunch of years ago now, because this is 13 years ago, they asked me to do a chapter on the future of dental maxillofacial imaging. Okay, I think it was a leftover chapter. And so I'm supposed to predict the future of imaging back in 2008. But I gave it my best shot. And one of the things that I said was, people were saying, is panoramic imaging remaining a standard of care for implant? And this was a question I got asked all the time back then. I said, in my opinion, it never really was a standard of care. I think everybody was placing themselves at risk because of panoramic errors, because of the distortion that is inherent in the machine. And when you make another error, you increase that distortion. So unless you're doing cross-sectional imaging of some description, I don't think you could do it. And cone beam had only been around at that point in time in earnest since about maybe 2005. It came in 2000, but by 2005, people were doing it. So at the time I wrote this, we were actually doing tomography with a different type of machine, not even cone beam. But currently, 2012, our organization, the AAOMR, came out and they made a bunch of recommendations, some of which I would challenge, but this one I think was appropriate. Cone beam should be considered the imaging modality of choice for preoperative cross-sectional imaging of potential implant site. I don't think anyone can argue with that. And I do a lot of expert witness things, and I've had 2 or 3 cases of implants where they shouldn't have been, and they're ongoing as we speak. But if you have the right technology or access to it, and you use an implant planning program and a surgical guide, you won't be able to go wrong. So, what are the reasons implants fail? Well, this popped up in Dental and Podiatry Malpractice Lawyers of New York, and they had it down. I changed this a little bit. I think I added one, but they're already looking at poor, improper angulation, nerve injury, improper placement, and infection. You want to avoid all of these things, okay? So we're going to talk about a couple. Well, we're going to talk about the preoperative planning. We're going to talk about improper angulation, maybe a bit about nerve injury and peri-implantitis. So we're worried about it. We're concerned. We're being professional about it, but there's a whole cadre of lawyers out there in North America that are licking their lips saying, hey, this is another revenue stream if we can find it. So if you think about it, for preoperative planning, you could reduce your risk by using CBCT. Bone quality, we'll talk about that a little bit, but you really can't determine precisely whether bone has a good quality or not, even with the best pre-planning tools, because it's really a measure of optical density and not of actual quality. Improper angulation, you can eliminate that. Nerve injury, you can eliminate that. Improper placement relative to adjacent teeth, where the terminus of the implant is sitting too close to the root of another tooth, you can eliminate that. Postoperative infection, sometimes that's going to occur, but if you're placing implants in a periodontally involved mouth, or someone maybe with undiagnosed type 2 diabetes mellitus, you will have cases that will get infected. So under the systemic things, okay, if you look at all of this, diabetes, very common, 80 million diagnosed diabetics and probably another 85 million, 40 million diagnosed and 80 million pre-diabetic. Knowledge of paranasal sinus diseases, and you're placing implants in the maxilla, so you have to know a lot more about the maxillary sinus and then its relation to the other sinuses. As far as these others go, there's good article science out there that you can read. I'm not going to talk about immunosuppression or bisphosphonate therapy, whatever. I'm going to concentrate because of time issues on the two. And it's not like, again, it's not like others aren't looking at this, okay? This was a statement that I took out of this law site. Some dentists will try to shortcut the diagnostic process by using two-dimensional panoramic x-rays. Well, if the lawyers are saying it, then you know they're already litigating it. So, you know, it's a problem because they're saying that you won't know the angles, you won't know the dimensions, you know, you'll be putting implants in places where they shouldn't be. Now, one of the things that happens is, and this was from Thomas Balshi and his colleagues, and they basically said, you know, we can place implants in diabetics if they're controlled, basically what the article said, and that's true. But they also suggested that screening for diabetes and trying to ensure that implant candidates are in control is recommended. Well, here's the deal. I'm going to go through a couple little stats to show you how much diabetes is probably out there that's unrecognized. And all it is a recipe for failure and maybe what you can do to help prevent that. So the symptoms, unfortunately, of type 2 diabetes are, you know, there's a bunch of them, but they can go on subclinically for years without being noticed. That's one of the problems. That's why we have so many undiagnosed pre-diabetic patients. So the CDC, at least they got this right. I'm not sure about masking and never mind, we won't go there. Diagnosing pre-diabetes, the simplest way to do it is with a hemoglobin A1C test. And there's magical divisions and guidelines to say, you're normal if you're below 5.7, but you're pre-diabetic if you're anywhere between that and 6.4. And you got diabetes if it's above. Most of you out there know this. What I'm surprised to learn is there are clients of mine, periodontists in particular, that actually do this in their office, okay? They actually do a hemoglobin A1C in their office. And I'm going to show you why when you identify something in your cone beam scan, you should think about ordering it or maybe even doing it in your office, because almost all the carriers cover it under a CDT code, D0411. So we're going to give you the 411 on diabetes in your practice. So 30 to 40 million Americans have diabetes and don't know it. Okay, screening for diabetes in dental practices. This was from a good friend of mine who passed away about almost 2 years ago now, Bob Genko in Buffalo. There he is there. We were out playing golf in Florida at a Cigna event because we do some consultation for some of the carriers. They looked at 1,000 patients. They did hemoglobin A1C levels on those 1,000 patients, and 40.7% had levels that were basically putting them in the pre-diabetic or diabetic range. 40% of just 1,000 patients at random coming into the clinic. So, and at a high probability. So the deal is, here's one of my friends. He doesn't know I'm actually showing this image. This is Constantine Farah up in Canton, Ohio. And I would be making these suggestions in my reports. Patients should be referred to their primary care provider for evaluation of hypertension and stroke risk, as well as undiagnosed type 2 diabetes mellitus. And then I'd say clinical evaluation or serologic evaluation should include serologic levels of hemoglobin A1C. And I called him up to say that to him one day, and he said, well, I already do that, Dale. I said, what? He said, yes, I do that testing in my office. So here's the code, here's the name, hemoglobin A1C in-office point of service testing. I don't know the reimbursement level. Very simple to do. You sit there with the tools. The patient does a pin prick. You read it at the time. I actually think I saw a kit in CVS the other day for $49.95 for anybody that wants it. So you can go in and buy it in the drugstore and do your own. But 86, I've seen different estimates, 80 to 86 million adults, okay? More than 1 in 3 people have pre-diabetes. Well, if you don't know that going in and you're planning implants, and then you put them in and you wonder why they're not healing properly, guess what? It's probably because they're undiagnosed. So consider it. I'm not here to teach you about it. I did get boarded in oral medicine and radiology, which is why I bring up these things when I think it'll help you in your office. So how does cone beam help me in detecting type 2 diabetes mellitus? Well, watch this. You saw an example of this earlier. This is your typical X-ray image. This is a MIP image, the maximum intensity projection. I use this for all suspected calcifications. This is where you guys are all excited, and most of dentistry gets excited. Here's a thin slice, 1/10 of a millimeter. I can do accurate planning. Yeah, great, but you've got these other tools in your toolkit with your machines. You better ask the people from Vatech, how can I use these? Okay. You can do a high threshold volume rendering. This is what I call the full 3D surface rendering. You do it for a mandible, maxilla, but look, they do it for the spinal column. And then we can't do this as well. This is a low threshold, adding in soft tissue, and that's a vessel, okay, probably aorta. So you can detect changes on cone beam scans that says the patient has diabetes. We got all excited about these diffuse sclerotic plaques in a site where we want to do an implant. Oh my God, this patient's at risk of hypertension and stroke. Yep. Okay, that's the carotid plaque. To me, this is more important. And are you going to see them? Yeah. This is a mandible. This is where the teeth are that you'll be assessing. And if you see these circumferential calcifications, you thicken the slice, you apply the MIP tool, and you can ask the people from Vatech how to do it because it's very simple in their software as well. So this is called intimal sclerosis or carotid atherosclerosis. Carotid plaque looks like that. This is called medial arterial calcification, either around the arterial wall or in other planes of section along, up and down the arterial walls. So I know I hit this a lot before, and I'm hitting it again now only because you're planning implants and you're focused on that task. But if you don't recognize and the patient doesn't know that they have diabetes and you see these calcifications, I wouldn't start the implant case until you got them tested. So the intimal plaque, they're deposits within the lumen, the MAC or medial arterial calcification. These are stained calcifications within the next layer, the muscular layer of the artery. So lumen, epithelial layer, muscular layer. This thing can't expand and contract. They can't get, and this is macroscopic level. Guys, this has been happening at the microscopic level probably for years. This is why their kidneys are not working as well. This is why they get burning fingers and toes. This is why they get retinopathy, because by the time we see this, they're pretty far along. If you see this, I'd put the brakes on your implant case, okay? So this is pre-surgical, pre-implant planning that you're looking at. The MAC is this stuff around the muscular layer. And it may be as subtle as this. This is actually the carotid artery. You know this is the hyoid. Here's another carotid artery. OMG, these calcifications are in both of those ascending internal carotid arteries. Let's thicken it out. Yep, confirmation, and I'll bet it's in other places too. Here's how easy it is to do in the Vatech software. You identify in a thin section, you go over here and change the basically the thickness, okay? You can click on it, the thickness, we're putting it 10 millimeters, and this is, and it'll pop right out, okay? I also see, this is mandible, obviously. You can see the airway, you can see the dens, and this is the anterior arch of C1. This is the foramen magnum, okay? This is the vertebral artery. It comes up and then goes, in through the foramen magnum a little bit higher up. So in this area, between C1 and C2, I often see calcifications. These are arterial calcifications in the medial layer in the vertebral arteries. Well, there's condyles. Are you going to see them? Yeah, you're going to see them. You probably will miss them until you start looking. All right. So that to end this little part of the section, plaque, most often solitary, disorganized, diffuse sclerotic plaque, arteriosclerosis, hypertension, and stroke. MAC, medial arterial calcification, multiple locations. They are organized in the patterns that I was telling you about, and it's more important to me. You can have lots of your arteries filled with plaque and never die. You could have 2% filled and throw a small clot and die. Okay, there's no correlation between the degree of calcification, but over here there is, and it's only now starting to be recognized. So 0.1 millimeter, 10 millimeter. This is what your MIP tool will do. Please check it out. And you'll see them in other locations, like I said. Okay. All right, here's my new recommendation. This is in the, I have software called EasyWriter. That was my disclaimer at the beginning. And this is what I now have put in my EasyWriter software. They need to be referred for undiagnosed type 2 diabetes mellitus, and it should include serologic levels of A1C, hemoglobin A1C. All right. Now, why do we see it up there? This is just, this is a really bad sinus case. This is the carotid artery, the internal carotid, and it has a groove in the sphenoid sinus region. So you'll see those calcifications in that area as well. Oh, I'm not going to see it. I don't have a big enough field of view. Yes, you do. There's the condyle. There's the stent. They already got their diagnosis. They had plaques. They got roto-rooted, and they got a stent put in, and they got more of it coming over here. I see calcifications here and here. I sound like the movie, don't I? Where do you see calcifications? Everywhere. Anyway, these calcifications are significant. I'll bet this patient's hypertension and stroke problem was really undiagnosed diabetes because they're all comorbid conditions. All right, off my bandwagon, on to the sinus changes. Most important thing I can teach you today is that if there's inflammatory change, there's some signs of chronic, which are these thickened mucosal changes, but there's some signs of acute exacerbation. If you see bubbles in any of this inflammatory change, it's an acute phase. They're going to have pain. And if the sinuses are involved and you don't get them under control before you're planning your sinus lift or graft material or going up there, you're just asking for problems. The paranasal sinuses are a bunch, okay? The maxillary sinuses each side, the ethmoid air cell complex is in here. These are frontal sinuses, and the ethmoids actually run into the frontal sinus. And then in the middle of your head, of course, is the sphenoid. But there's an important piece right here is an opening here and here called the ostium, maxillary ostium, because there's ostia for these other spaces. But if you get crud in this sinus space and it can't get out, because everything has to go into your nasal cavity and then be spit or swallowed, you're in trouble. So you've got these sinuses and you've got an ostium, and if you block that ostium, nothing can get out. So crud in here can't get out here to be drained through the back of the nose. Don't do the implants. The other ostium, here's one from the frontal sinus into the superior turbinate or meatal area, and the sphenoid sinus also communicates with the ethmoid air cell complex. So I see changes in the sphenoid sinus all the time as well. But this is what I'm talking about. The ostium right here, if you're doing a maxillary implant, if it looks like this, I'm not that worried. I am concerned about this, and I'd want to do some more imaging or get an ENT consult. But this guy has an opening that's patent. This is called the uncinate process, and this is a clear maxillary sinus with open patent airway right into the middle meatal space in the nasal cavity. Here, there's some inflammatory change, and there's already some inflammatory change here. If this is really truly blocked, this can't get out and it will build up, and nothing that's above can come through that area as well to get into the middle part of the nasal cavity. And I see this a lot. Here's a tooth that's going to come out. You're going to plan the implants, got a big lesions, got all this sinus change. I wouldn't touch this with an implant for, ever. Okay, here are the reasons why. If you look at the lateral walls of the sinus, you can see these are much thicker on here. This says that this change has been going on for a long time. This tooth has to be removed. This stuff has to be removed. It's blocked the ostium and blocked up the ethmoid air cell complex. This guy's probably got unilateral facial pain, referred pain, dental pain, all of the above. This is a combo endodontist ENT patient before you do the implants. Just think of it as pre-prosthetic planning or pre-surgical planning, okay? And even if you have this is an 8x8, even if you have a smaller field of view and you think you're not going to see it, you're going to see it, okay? Because you'll pick up the maxillary antra. Here's the crud in the left antral space or left maxillary sinus, the blocked ostium, and it's actually going into middle meatus and into a thing called, an anomaly in the middle turbinate. So here's a patent opening, here's a blocked opening. This ain't getting better till it's cleaned out. There's another case. This is where I think you've put yourself at risk. Someone wanted to place the implants, was bent and determined they were going to place the implants. Inflammatory change happened around one of the implants because both of these are in the maxillary sinus. If this came to me and they said, well, do you really think the implants are in the sinus? I'd say, yep, look in the other plane of section. This definitely penetrated. And I'd say, yep, look in the coronal section. It's definitely into the sinus. If you put a foreign object, I don't care if you think you did a beautiful sinus lift, it shouldn't be in there. And this inflammatory change is not going to go away. If the patient has lots of signs, symptoms, and other problems, they're going to blame you. Doc, I can't breathe. I got runny nose all the time. My implant's loose. I can't have relations with my wife because my breath stinks, from all the sinus changes. Well, he probably already had sinus changes, but you didn't make it any better, so you get blamed. And I can actually show them in 3D too. This is actually the threads of the implant coming right up into the sinus. So if this came to me and it was an expert witness, I'd say, yeah, this dentist perforated the left maxillary sinus, and within a degree of medical probability, he caused the sinus problem in that maxillary sinus. I don't know about the rest. Oh, by the way, he also put 3 in the right maxillary sinus. This does not happen with cone beam CT. This happens with inadequate imaging. This happens in the hands of someone says, oh, I just need a panoramic and a couple intraorals so I can measure more precisely. No, you don't. You need CBCT and you need an implant planning program. So here are 2 fixtures that are in the right maxillary sinus. This patient had absolutely no complaints, but this is just asking for something down the road. Look at the thread. We're looking from the top down into the maxilla, into the sinus, and you can see the thread. There's an AO defect. There's an anteroral defect, which could have been avoided. Maybe they needed more graft material. And I put the lining on this one. The green is the actual membranous lining of the sinus, but I can still see the implants up in there. All right. So a couple of conditions you should be aware of. Please learn all you can about the paranasal sinuses and nasal cavity, not just the maxillary sinus. You need to know everything you need to know, okay, about all of the sinus spaces, including ethmoid air cells, sphenoid, and frontal sinuses, and the nasal cavity as well. Lots of things occur in there that if you don't diagnose them, they're going to basically not help you with your implant case, okay? You got to get your patient healthy first before you do the implant. Types of failures, cortical perforations, sinus perforations, peri-implantitis. How to avoid? Well, there you go. You can avoid all of these things using the software planning tools with your machine and getting good data, making a surgical guide. And I think you need to think about always providing really, really close follow-up and postoperative care, because the ones that go south are the ones that, well, there's some minor periodontal problems, and I got it in there because I'm setting it up for future rebuilding of a occlusion, and then they go away and you don't see them for 18 months, and all of a sudden the implant's loose. There's peri-implantitis. Their periodontal disease didn't get any better. So this is in your office, this is a multidisciplinary approach. You and the hygienist and assistant have to make sure that that patient is getting the best treatment possible. All right, cortical perforations. If you only use a panoramic, this looks good. However, if you have three-dimensional imaging and you can see other planes of section, you can see that there may be some bone over the facial surface of an implant, but maybe not. Well, if you got tools to do the surface rendering, go ahead and use them. And there isn't any bone. There's a fenestration over the implant surface. And you can see that there's been a little bit of loss, but you can see the threads of the implant. And this isn't diminishing returns. I actually played with this until I put all the bone I could put on without getting a lot of scatter and other artifact. And that's as much bone as I could put on. So this is different software than you would see in your Vatech machines, but you can do similar things. And it showed, why did this fail? Well, I guess he wanted it for aesthetic reasons, right? The implant doc, I'm missing a tooth up here, got knocked out. Well, okay, but why don't we think about getting the periodontium under control first, or at least advising the patient that, maybe you're not a great candidate for implants until we have our periodontist consult, some disease under control before we do the implant. And you can't tell that from here. This looks great. Yeah, level looks good. Did a short implant, lots of bone. Sure, there isn't. All right. This one just blew me away. I had to put some measurements on it. And again, no cone beam was done planning this implant. And you can see that they probably said to themselves, oh, I can put a finger on each side of the buccal and the palatal cortex, and I can determine the angle that my implant's going to go in. No, some of you can't. Okay, I'm sorry to say it. I've been there myself. I did a lot of surgery in my dental practice, and there's a learning curve, okay? But if your learning curve is actually eliminated or reduced quite a bit by using good imaging and a surgical guide, why not do it? I mean, look at how much he had. This guy had over 13 millimeters probably of bone, okay? I'm sorry, the implant was 13, almost 13 millimeters. The guy had almost 20 millimeters of length. So if he could have actually hit the middle, he would have had a great implant, would have been there for 20 years. And you can see what happened. There it is in 3D rendering again. And I always hate putting these images in, but I put them in with big bright arrows, and I said there's insufficient bone over the facial aspect of the implant replacing tooth number sign 7 or whatever. And the report goes back to the referring doc, and then they go, oh, guess I got to take this implant out. Patient is not happy. Here's another one. This is the nasopalatine foramen, by the way, but the facial aspect of this one is it's a little light. And here's with the 3D imaging. I don't care about the scatter and the other image quality here. I'm just looking to see if I can put the bone back on here with my 3D sort of threshold rendering, and I couldn't. And not only that, didn't have sufficient bone over the facial aspect, they also placed it so close to the midline that they actually impinged upon the nasopalatine canal and foramen. And you can see, here's the foramen, there's the threads. So if any of you get into trouble and you need expert opinion, I do that as well, but I'm trying to I don't want any of you as my defendant in any of these cases. I want you to use the tools and not place the implants where they shouldn't go. This guy also had other problems. This was a lesion he had on This was international numbering because I did this lecture elsewhere, but this is tooth number 14, and you can see the huge periapical lesion. You can see there were lesions on other teeth, okay, first and second bicuspids. I mean, this guy's disease was not under control. There was secondary caries, external resorption, all kinds of things going on in the rest of the mouth. And what did they do? They put an implant in the front. So here's the deal. You know, I want you to think about, you know, treatment planning. Treatment planning is poorly taught, I think, these days in dental schools. Myself and my colleagues in academia spent a lot of time trying to get students to understand the sequencing of treatment. And many students graduated and went, oh, I just want to put an implant here. I just want to put a 3/4 gold unit on this one. Now there's people like Frank Spear and the Pankey Institute that basically re-educate you. Everybody gets all excited. Oh, you should see what I learned there. Yeah, well, some of you didn't learn it in dental school. So now you got to go pay somebody else to take you through it. And I know I practiced long enough to know how many things are out there that you have to master. And it's not easy. Being a dentist is tough work, but you got to think about some of the parameters of treatment planning before you start your cases. And I took this off the internet. I typed in, is treatment planning taught in dental schools? This was in October of 2020. It's a critical aspect. It's surprising, therefore, so little attention is given this in the dental literature. That's a sad statement, unfortunately. All right. So again, Osseo News, they show this. I love this case because this image is upside down. This is the same implant in all three of these. And it looks like it's ready to restore. Oh, okay. Well, they did restore it. What about this? This can't be anything but a carious lesion. So how are they not treating that? Next thing to go is this need a root canal, and then that'll fail, and then they'll have to have another implant. Well, you know, treatment planning should have been sequenced somehow. All right. Here's another case, and this is kind of improper placement and or angulation. If you look at this case, it looks, I love it when, and all the manufacturers are guilty of this. Let's make it look nice and clean by not showing full, you know, threshold, full surface rendering. Some of these look pretty ugly. You show that to the patient, they go, my God, what's all this going on? Well, you know what? That's what the bone looks like. And sometimes we can't get rid of some of the scatter and other artifact that's in there. But if this were the guy, maybe they were trying to, you know, stabilize the right side occlusion so that they didn't lose any more, you know, vertical dimension, or nah, I don't know. In any event, there's a lot of bone loss going on here. Why would they place an implant in that area? Look at the end result. Now, if you see radiolucent zone like this, that's a peri-implantitis. I'll show you more later. But you don't even have to just start interpreting gray and black around the implant surface. You can see it in a full color 3D image. Here's another one, placement problem, facial. I'm showing you these a lot in the anterior. Look at, he had room probably. You didn't need that wide an implant, but you know, the end result is it's sticking out of the bone again. You can also perforate into the maxillary sinus. We saw a couple cases earlier, and I showed you these things about the sinus space. There are other considerations. The orange arrows looking at the middle turbinate, and this is an anomaly called concha bullosa, just means a pneumatization of that area. The left side middle turbinate had that same anomaly, but the inflammatory change got inside it. This can give you mid-face pain. This can give you referred pain. So you may be blaming the sinus, and yet it's not just the maxillary sinus inflammatory change. It's gotten into other regions, okay? That's called concha bullosa. And you want to put an implant here, that's great, but you better not perforate the sinus, and you better diagnose all the other conditions. All right, case number 4, again, improper placement. There's an implant here. I don't know if you saw it because there's a lot of scatter artifact in this image. There's some bone loss here and there. These are just areas where we didn't quite get all. If I did some image processing to make the bone fill in here, we'd have even more scatter artifacts. So there's diminishing returns. But I want you to see this implant. This implant, how they thought they had enough bone here is beyond me. This implant is into the right maxillary sinus. They probably planned from a panoramic, and they didn't need to. And you can see all this inflammatory change. Well, it's isolated to that right maxillary sinus, and it wouldn't take much for me to say, I think the impingement of the implant into the right maxillary antrum was the, resulted in inflammatory change that gave the patient a full maxillary sinusitis if they were complaining. So I want you to pay attention to the radiographic changes. In this region, a little bit further posterior, the bone doesn't look too bad. It looks very similar to the other side. As we come more anterior, you can see that the bone is thickened and what I call hyperostotic. So this is a very, very long-standing change. You need to get that under control before you actually place the implant. And this is, I still believe, the same case. You can see the implant, you can see the inflammatory change. There it is. This is coming from the opposite side. We're actually on the palatal side looking towards the right. And you can see that this implant basically was embedded right into the maxillary sinus. And there it is in the superior view looking down into the sinus. Okay, I had to see what this one almost looks like the last case all over again. But if you look at this one, you can see an implant. You follow the antral floor on both sides. Maybe there's some inflammatory change. I don't know. You can't even make, you can do radiographic interpretation, but you can't make a good clinical impression out of this. You see it in a different plane of section. This is a sagittal view. Tooth number 4 has penetrated. And there it is again in the antral space. I could show you case after case. This is so disturbing to me because you're my colleagues out there. I don't want you, first of all, doing that. Don't want the patient to have to live with that. And I don't want you to have some attorney after you in litigation because of this. So you need to use all the tools you can. Where did it all go wrong? Well, a lot of times it goes wrong because basically you haven't paid attention to. Look at some of these. I go to these sites all the time because I have to stay current. But failure to diagnose periodontal disease down here on the lower right, that's become something that's on every law firm's website now, and also oral cancer. But this one was, defective dental implants. Was there negligence? Well, if you don't diagnose periodontal disease, that's probably negligence. Why does it happen? Well, we're task-oriented. Dentists, I'm a guy and I'm a dentist. I want to get the task done. I want to help the patient get my surgical piece done and restored. Well, here's a guy that sent an image to me. This is one JPEG, screenshot of his implant planning. He was all excited about getting new software. And he totally missed all of the inflammatory change in the left maxillary sinus. Is the patient going to die? Absolutely not. But he sent me this one as well. And a colleague asked him, what's that large egg-shaped object in the sinus? He hadn't looked. And so the statement that he sent back to me, because I gave him my opinion just in an email, and I said, can I use your email back to me in a lecture? And he said, absolutely, just don't tell anybody who I am, because he was a big trainer in implant care. Believe it or not, those are quick captures they took out of VIP, which usually doesn't give a great image, but the new version's much improved. Scared the crap out of me as the patient was a patient from hell, smoker, then diagnosed diabetic after the treatment started. I got so tunnel vision on the Noble Guide setting up that when a colleague said, what's that egg-shaped object in the sinus, I hadn't even bothered to look. Nothing like taking the time, do advanced imaging, gather all the data, and ignore it. Don't be this guy, okay? He learned a lesson the hard way. One of the things that I have had to educate myself in, because I never placed implants. I was to go into a program with an understudy of Brandemarks at the University of Toronto, and I decided to heck with it. It was going to take too long in Toronto, so I came down to Texas to do my graduate work. So I never got to place implants. I got to learn about implants because I had to teach dental students about the pros and cons, pitfalls, and way to do it. But I didn't even know that there was an actual categorization for the peri-implant, sort of problem, the peri-implantitis. And there are criteria for making these particular distinctions between a mucositis and a peri-implantitis. And you guys know far better than I do. I know what I see in the radiographs. These are 2 digital images. If it looks like this around the implant, it's probably okay, but I'd want to see other information, maybe even cone beam to, people say, oh, look, that bone is integrated into the thread. Yeah, well, that's 1 degree of 360. How do I know what else is going on around it? But if I see this type of appearance on an intraoral or panoramic, I know that there's a clinical condition called peri-implantitis, and this one is more severe because there's been dissolution of the bone in and around the implant fixture. So this one's not long for the world. So that's, this is what we're looking for. We're looking for those types of changes. Well, in cone beam, you can see them even easier because you have different planes of section. This one almost looks like there's a big defect on the lingual surface. And you can see that there is some type of funneling kind of radiolucent defect around the neck of that implant. It's still got probably lots of years, but you've got to get the inflammation under control. Otherwise, you're going to be sacrificing that implant. In this case, because we did a MIP image as part of it, it makes it look pretty good, but that you can't use that to diagnose with. So thin slice grayscale images, maybe 3D in some cases. I always do a 3D image. So this is showing me the interface between the bone and the neck of the implant before the restoration. So most likely I would suspect clinically there's going to be some reddening, some inflammatory change around there. There might be some probing depths if you look. And this is the same, this is a different implant, patient's right. You will get dark areas between the implants if there's a couple close together, but this is artifact, okay? This is basically loss of the signal in between as the machine rotates around. And so you don't get full fill-in of that tissue. If you see radiolucency that's not between them, that's adjacent on any of the other surfaces, that is peri-implantitis. So this is the same case, imaged 3 or 4 different ways. And the other tooth, the other implant looked pretty good. But in this reconstructed thin slice panoramic, I'd want to examine this very, very carefully radiographically or clinically. So here's what it really looked like. This is the posterior part of the implant and then the buccal component over here. And you can see that, yes, there is definitely a failing implant in that spot. All right, incorrect dental placement again, and this is more of an angulation problem. I took these off the internet. I didn't do these. I didn't get these sent to me, but I know enough to know that those 2 implants as they emerge don't have the appropriate orientation, the emergence profile of the restoration. When you restore this and restore this, you can't do it from this case. Even this one, this implant orientation should have more sort of alignment with the rest of the space between the bicuspid and the molar. So both of those are possibly failures. Now, yes, you can angle, do an angled abutment and restore that somewhat, but it's not ideal. Ideal comes from basically using cone beam and a surgical guide technique. I love this cartoon. I did use extra long implants. I wouldn't want to be that doc. Okay. Now here's another, I go, like I said, to Osteo News quite a bit. This one says I had an implant placed. This is the patient now. I had an implant placed 3 months ago. It was hidden below the gums. Last week, the cap was placed, and I started to wonder if the placement was correct. Isn't it too close to the adjacent tooth? And then he had some dental lingo that he picked up on, the buccolingual side. I've decided on an implant after 15 years of missing this tooth. So there were a couple replies. One of the, and this is what it looked like. Okay, he thought it was too close to this tooth. Basically, you and I know that it's probably, too far lingual as well, but that may be just from the ridge atrophy. And you can see that if this is the panoramic, it is close to that tooth. It's been placed so that it's almost sitting on the apex of tooth number 29. So one person said, this is nothing to brag about, but it'll work. Much rather have it too far lingual than too far facial. Too close to 29, but as long as the pulp test's okay, don't worry. This is like fixing a problem that you created in the first place, and you didn't have to have this problem. So basically he's saying, just go ahead and restore it. Whereas another responder said the implant probably was placed in its lingualized position because of atrophy at the expense of the buccal bone. Such bone loss is to be expected. And yes, the implant is woefully too close to the premolar. These deficiencies will lead to all sorts of problems during and after when it comes to placing the abutment and crown. So what he's saying is, you know what? I would take it out. I would, let it heal or put in graft and then, go and revisit it at a later date. I tend to agree with the second guy. It's kind of like you're in dental school. If your impression wasn't proper when you took it the first time and you didn't retake it, everything goes downhill from there. So here's another one. This implant looks like it's a pretty good orientation. It's got good height. I can barely make out the canal, but it looks like it's at least at a sufficient distance from it. They've had successful implants placed in the maxilla. So let's look at this one. Well, there are two implants, and you can see that one of them, this is the one they were looking at, but the other one, this one that looked good, it's really too close to tooth number 21. And it shows up even better in the 3D reconstruction and in this axial view. So, again, these could have been avoided by using the proper imaging technique. Okay, I'm sure these weren't done under guided construction. Here's another one that, this is a different one. It looks very similar to the previous one. This one's too close, and this one looks like it's in a reasonable position, but this one is also too far facial. And you can see there's insufficient bone over the facial aspect. How do I know? Well, I do the 3D reconstruction and show it. When I go up and I would teach at Gordon Christensen's PCC program, he always talked about first, replacing the first bicuspids with the wrong orientation and putting them out the side. Well, here's a typical case that he's talking about. These were not centralized in the alveolar ridge. They were just placed, again, probably without proper implant imaging. So these are failures. I see so much. I could go on, but I'm not going to. Here's a case of implant in the canal. Well, I don't even need to do sexy imaging to see it in the canal, but some of these canals are not all that detectable in these mandibles. This is a very old scan. This is probably 12 or 15 years one of my first cases. And this is one of the ones I used the endoscopy tool on because someone said, would I see an implant in the canal if I use the endoscopy tool? I said, yeah, I just don't have one. Well, 2 weeks later, I found one. And I didn't need the endoscopy tool. There's periimplantitis going on. This 15 millimeter implant should have been 12. And you can see where the end of the implant is impinging on the inferior alveolar nerve canal. We could have painted it first. If they'd done it with cone beam, you would have seen exactly where the nerve was and you wouldn't have gone into it. In this case, we were able to show that it impinged in, both the sagittal and the coronal views. And then I did a this is called a slab rendering. I didn't mention that to you, but this is thickening out the slices, but applying the color tools to it. And you can see the inferior alveolar nerve canal coming here and the implant in it. But I did the endoscopy tool. And the endoscopy tool was cool. I went in the mental foramen, and then I started to go down through the mandible in the inferior alveolar nerve canal. And there's the canal, and there's the implant. So this was actually a legal case, and this one was settled immediately upon viewing these images. And I didn't even have to do this, although I did. I labeled it implant and canal for the jury. And when the opposing counsel saw this image, he said, okay, what do you want to settle for? So, all right, case number 9, this is a fun case. This is where I'm going to basically, I guess, try and convince you that if I were restoring areas that had been edentulous for a number of years, often these patients are older, and often they have some type of osteoarthritic problem going on, either by history, by looking at their knobby knuckles on their hand, by asking them, oh yeah, my knee, my hip. Well, I always want you to look at the condyles, because if you start to restore with implants and put them back in function, sometimes this is basically osteophyte production, flattening. Even the articular eminence is involved on this one. So they've got bilateral osteoarthritic changes, and that might flare up when you put them back in function. And then they're going to blame you for their joint pain. So it's a lot easier to start with imaging, say, Mrs. Jones, you've got a spur, you've got some osteoarthritic changes on these things called condyles. When I restore you, that might flare up, but don't worry, we'll treat it with some non-steroidals. We'll give you moist heat, and things should settle down once we get all your areas restored, okay? And it's real easy to image and see the changes. This is axial plane of section. You can see subchondral cyst formation, gross remodeling, both condylar heads, osteophyte formation here. So my feeling is that you should, this is a terrible case to image too. It didn't have a lot of high detail in it, unfortunately, but definitely both a bilateral osteoarthritic change and gross remodeling. This is called lipping here on the condylar surface. So this patient is, they're okay to do the implants on, but you have to at least coach them through what the potentials morbidity is, that you might create. And these are the sagittal views, right and left condylar views. And by the way, guys, if you're new to listening to me, I just want to remind you, cone beam images don't come with arrows. Okay, we put those on in our reports to help identify those areas that we think you should take into consideration. And this patient has OA of the spine too. This is vertebral body C2. This is C3 with osteophyte formation here as well. They don't have much of a severely atrophic maxilla to build those implants on. So we can all do better, okay? How do you do better? I want you to do a much more rigorous and thorough check of the patient's medical and dental history, especially for the condition diabetes mellitus. And if they have any family history, if they are talking about the cardinal signs of, overt type 2 diabetes mellitus, I think you should just stop the presses at that stage and get their A1C level determined, or send them back to their primary care provider to determine that. If they have any periodontal disease, and you're worried about that, and they say, yeah, I brush, I floss, I do all the things, and they've either got an underlying, blood dyscrasia, or they got diabetes. So I think you need to spend a little more time, not just go to your task of planning the implant. You need to assess the patient's medical condition. When you do obtain a scan or the scan data, if you refer it out to somebody else to do the scan, you need to use that scan and the software within it for planning the case. you can't, I know, and I've had these discussions with Gordon. Oh yeah, we make a model and we, it's kind of like eyeballing again. I don't trust it. CBCT is an accepted technology. The software that comes with it for implant planning or third-party software is exquisite. The measurements are accurate. The fashioning of a surgical guide from the cone beam CT data is simple, okay, and it doesn't add that much to the case. And it certainly will reduce your risk. It'll reduce any postoperative morbidity that might occur, and it'll make your patient a lot happier. And when your patient's happy, you're happy. Okay, that's what we're here for. Get them functionally restored so that they can, be good again. Chewing. I think you should, and even those folks out there who may not be using a guide that have been doing implants for years, if you're long past the learning curve, fine, more power to you. But when you start using a surgical guide and use it in a protocol, it's not difficult. You image 1 week, do your surgery the next, or 2 weeks later, whenever you get the guide back, and it makes it so easy. I want you to think about having a protocol in the office for post-surgical care. Follow up with the hygienist, instruction at the time before you let them go, close monitoring radiographically, post-operatively, maybe at a 3-month, 6-month annual interval initially, and determine, are they the patient that's only losing that 0.5 millimeter a year of bone, or have they got some other problems going on where they're not in control, or they didn't do their oral hygiene the way they should have, and now they've got more bone loss than you would expect within a short period of time. There are some resources. They're not for the implant planning, but for some of the other things that I showed you. One of them is my website called drconebeam.com. I have bunches of articles on that website to help you understand the technology better, links to textbooks, links to anatomy, little applications that I do on Apple. So that's one of the resources. This is what the entry page looks like. I'm a little older now. You saw my picture at the beginning, but I don't sell anything on here, but I have links to the products that I've helped bring to dentistry to help you be a better clinician. I've read well over 30,000 scans now, and it still surprises me what I find in them. There's also a textbook. You probably, I don't know if when my screen comes back, if you look over my right shoulder, your left side of the screen, you'll see this book sitting behind me. It's Shameless Self-Promotion. No, I'm just kidding. I'm very proud of this book. It's just about out of print, the second edition, and the deals on it are unbelievable right now. If 1 or 2 of you buy it, my kids can have shoes. Okay, so just want to share that with you. For implant planning goals, one of the places that when I was reading through the recommendations of the AAMR, post-surgical assessment is not very well done in cone beam. Yes, you can do it. There might be some limitations because of scatter artifact and other things. They were suggesting periapical imaging because of the detail, but my feeling is you use whatever modality gives you the information that you need to determine what's happening with that implant. I think everybody should place implants. I know I admonished a few of you at the beginning and said, well, a lot of you can't do it or won't. But with a surgical guide, every dentist should be able to do the onesies and twosies. You think you can eyeball this and split the difference and place an implant in there? I don't think so. I think especially if you're starting out, you should use the technology that's available and you will not get into trouble. One of the earliest ones, I'm just about finished here. One of the earliest things that we tested out at Indiana University was Simplant. And they were selling the software and a computer. And the whole system was $60,000 just for the computer and the implant software. And oh, by the way, you had to send your patient for a conventional CT, which then you sent off to Simplant. They truncated the data from the head and neck CT down to the dental bases, And with the planning tools, you could place an implant, make some measurements. We are so far beyond that now. I don't even know whose program this is, but you can see we can map the nerves. We can measure to within 1/10 of a millimeter. We can drop in basically the implant sort of that we think we want to place. We can rotate around it. We can move it in different orientations so that when we make the surgical guide afterwards, you know it's only going to go down this far and it's going to be precisely at the right angulation that you need. So there are lots of programs out there. I would, if you're continuing with the Vatech folks, they have some really easy implant planning software. I've not played with it myself. I'll tell Jim I still need to get a trial version so that I can play with it a little bit more. But you know, when you can do these things and map out nerves and stay out of trouble, that's our goal. We don't want to place them into the canals or too far facially or lingually. Most implant will allow you to assess 360-degree around the programs. If it doesn't come out properly, I always do this one as a demo in my lectures. I can take this and rotate it in real time and put it in the proper orientation. And because the database is relational, it shows it properly in all other planes of section and 3D reconstructed views. So the implant planning is pretty simple to do. There's a couple screenshots that I took off of the internet showing the Vatech interface here with the Easy 3DI, and it looks like it's very simple software to use. So please, and I know they do courses periodically, you should look at you know, the way that they show you how to do it. This was international, I call it a magazine. They have some very good articles, but a lot of times it's more to help promote your office. But this implant practice, there was a 3-part series on the essential guidelines for using CBCT for implant imaging. I've not met Johan, but I corresponded with him about a week and a half ago because I was telling him that I'll be coming to South Africa. He practices in Cape Town. And I said I'd like to meet him because he did an outstanding series. One of the things I liked about it, this was an ego stroke for me. He had a lot of references, and a whole bunch of references were from work that I've done previously. So he is looks like a fun guy. I want to meet him and drink Western Cape wine with him somewhere and talk dentistry and implants. All right. He did put in, however, the limitations, and I did take exception to a couple. One of the limitations of doing implant with CBCT, it requires training and has a learning curve. That's not a limitation to me, that's a challenge. I think that everything that we do in dentistry requires training, sometimes postgraduate, sometimes, you know, real world. But that's not an impediment to me. If you're gonna do it, you gotta learn how to do it. It requires expertise and specialized equipment. Yeah, that's why you guys are already using it for certain things you do now. And that specialized equipment is going to make you a better dentist. I agree with him with the poor soft tissue contrast because there's some issues there that cone beam hasn't sorted out yet. It isn't like conventional CT. It's not he said this, and I said, thank you so much, Johan. I've been trying to teach people this for years. There are tools to assess they call it bone quality. They're really looking at the density, and it doesn't matter because if you have really thick, really dense, hardly any, you know, marrow space pattern, compact bone, sometimes it's still like mush when you drill into it. You can have cancellous big spaces, looks like it shouldn't hold anything, and the implant's in there solid as a rock. So there's no correlation really between some of the tools that are out there. Use it judiciously if you have it in your software. There are imaging artifacts we can't get rid of. We can reduce them. You can do error correction sometimes in the programs. And the dose, this is coming from Europe. Europe and South Africa, they're kind of like, you know, sisters in this respect. They basically are all worried about microsieverts, And the dose is so low that I don't think it even should be a consideration. If you've got a great piece of equipment that helps you do good surgical dentistry, then you need to use it. You're not irradiating areas that have that many tissues that have, sort of high radiosensitivity. Parotid, yes. Thyroid, yes, but not in adults. Brain tissue is relatively radio insensitive. So take a look at their software, have them walk you through it. There's lots of guide companies out there, lots of software. Here's my shameless plug for Easy Writer, the CyberMed people. This is my decision support software and report software. And if anyone's interested, you can go to the Easy Writer site and take a look at what it does. Here's one of those things that I just threw in at the very end. You're going to see odd things sometimes. No one in this audience probably knows what they're looking at. My pathologist friend and colleague, Bob Danforth, calls these chicken spurs. I don't know where pathologists name everything after food anyway. But this is actually calcification of the longitudinal posterior paraspinal ligaments. And it's quite a common finding. You can find it anterior and posterior, but don't be alarmed when you actually, this is a MIP image, when you do some of these images that certain things pop out and you go, OMG, what is this? Well, it's an I don't knowma. Okay, if you don't know what it is, it means you get a referral. So we have lots of my colleagues out there ready to accept your referrals. So in closing, I want you to assess the history, image appropriately, determine the best treatment, sequence that treatment, use a surgical guide, provide a maintenance program, closely follow the patient. And if you do all that, you'll have a very successful implant practice. Forgot to tell you about this. I just discovered this. In the Easy 3DI, they actually have clinical animations to help you educate your patient as to what you're doing and how simple the techniques are. But they're only simple if you do it using the tools we talked about. So I want to thank you. This is my my front yard early in the morning. I showed you the backyard in the evening, but we get some pretty interesting skies these days. So thanks so much. I will answer any of your questions at this time. Here I am again.
Hey, Dr. Miles, this is Jim. We
Yeah.
do have some questions coming in,
Good.
and thank you for your presentation. Very informative.
Okay, Dr. Miles, thank you for that.
This is not vodka and tonic. I'm just wetting my whistle here with water.
All right, the first question here is coming from Joseph for Dr. Miles. Are there hints for osteoporotic disease on the CBCT?
That's a great question. I see lots of what I call, in radiology, we use the term osteopenic, okay? And we mean that the trabecular pattern and the actual sort of cancellous bone looks different, okay? It looks like there's missing bone in the spinal column is the prime place we see it. And I'll make comments like there are the vertebral bodies C2, 3, and 4 appear quite osteopenic. Osteoporosis should be ruled out. So just the bone looking significantly different, that has more radiolucency to it, odd trabecular pattern or cancellous bone pattern, that might be a clue. In the jaw bases, it's more difficult, I think. I see lots of thin slice CBCT views that you look and you go, God, that mandible looks strange. And yet you look at the other side, it looks just the same. That's when you have to correlate the radiographic appearance with the patient's, clinical history and medical history, and ask them, anybody in the family, have you had fractures in the past? Whatever it is that you do to help sort osteoporosis out. I will tell you there's one sign, and I could probably find it and then get back to my screen to show it to you, but in vertebral bodies C2, 3, 4, and 5, because that's primarily what we see, Sometimes I'll see what I call a compression fracture. Not my term, it's a medical radiology term, and it looks like a little linear line, sometimes interrupted, that starts at the cortical bone in one of the vertebral bodies and goes partway through or all the way through, and it just looks odd again. And in the lower spine, they're quite common. In the cervical spine, maybe not as common, but I actually embed a statement about compression fractures and show a little icon or a little diagram of it. Let me do a quick thing here and I'll show you what I mean if I can. Can you give me back my screen,
Yes, Doctor,
Jim?
we can still see your screen there.
Oh, you can. Okay. So I opened up a folder that I have, and inside here it says compression fracture, and then it's got you know, a report that I can't show you because they're named, but this is kind of what it would look like. Okay. And some of them are more overt. They will go further through. Sometimes you'll have more than one vertebral body where it shows. This is another kind of appearance to it. To me, and you know, I can't have a histologic confirmation, but even the bone around this, does this not look like a little altered pattern? So this is, again, if you see something like this without an arrow, this is an idontoma. You can send this up to an oral maxillofacial radiologist or neuroradiologist or someone that does head and neck, and they'll basically, you know, give you an opinion on it. But that's kind of the things that they look like. Okay. Yeah, I don't have any additional ones. That's up a little bit higher up. The one I showed you was in C4. This is C3. So this bone looks a little osteopenic. Okay. You'll be looking more at mandibular bone, right, or maxillary bone, and you'll have to hunt the literature up for that to basically convince yourself that something's going on there. There we go. Okay, next question. I hope I answered that. And by the way, Jim, let me give them my email address. If you have other questions at the end, sometimes I don't get to them the very day. I get a bunch. miles.dale@gmail.com, and you can send me your question and I'll do my best to give you a cogent answer and reply in a timely fashion.
And we will provide that in the follow-up email that everyone will get.
Oh, okay,
So
great.
everyone will have your contact information there. Kind of leading off of that, I do have another question here from Dennis is, if the sella turcica measures more than 9 millimeters, does that indicate acromegaly?
Acromegaly.
Pardon my butchering of that word.
I'm just glad someone out there is looking at the sella and doing measurements. I don't have it in front of me here, but I actually have a little cheat sheet table, and there are dimensions for AP width and for height, okay, of the pituitary fossa, you know, from one edge to the other. And 9 would be, I still think it's within normal variant, but if you're really concerned and you're thinking it's acromegaly, you can't make the diagnosis anyway from an enlarged sella. What you have to do, they have to do the serology related to the different endocrine secretions that the pituitary covers, and that's a lot, both male and female. So I know in the past there was a really good article, and it was actually in the law journals as well, where an orthodontist who was doing traditional 2D cephalometric imaging, and they start in sella, right, SNA, SNB, did not think anything of the enlarged pituitary fossa and sella size. Kid ended up with acromegaly, but you know, acromegaly, you're going to see changes clinically, and you know, an endocrinologist or a good internist can, if you think it looks large and the kid looks like he's, you know, growing too fast or whatever, get them to the appropriate individual. Don't make diagnosis from your one measurement on a pituitary fossa. Okay.
Perfect.
Other question? Yep.
Yes, so I think this next question is going to be about, you had touched on implants, and especially on when we have very thin cortical wall on the anterior cortical plate, or where the implant is perforated. The question is, when there is a cortical bone perforation and the patients do not have any problems, do you still remove the implant?
That's probably above my pay grade. Okay, when a good rule of thumb is the first do no harm. All right, but never let the treatment be worse than the actual diagnosis. So if you think there's insufficient bone, all I do is I report what I see in the radiographs. It's up to the clinician to determine. If you palpate and the patient says, when I put my finger up there, I actually think I feel the implant just beneath the gum, it may be an issue. If they're asymptomatic, you may just want to watch it. I don't think it's going to get any better, although that function on that implant is not direct. It's coming on from the occlusal forces or incisal forces, but constantly doing this to an implant with not that much facial bone over it or none possibly can't get any better. So it's a clinical judgment. You'd have to take each case individually, and each patient's signs and symptoms along with it. That's just good sense.
Right. Thank you.
You're welcome.
Couple other questions. I have one that says, when placing maxillary implants, should I be concerned with imaging up to the ostium, placing maxillary implants in general?
Again, good question. I always hearken back to correlating, clinical signs and symptoms and history with whatever you're going to do. One thing we forget is that, yes, we can do great imaging, and do I always take one right up to see the ostium? Well, if there's no need to, I wouldn't. If you have signs or symptoms that suggest there might be some type of allergy, asthma, hay fever, perinatal sinus disease, definitely I'd go up and see the ostium. But if there's a lot of inflammatory change in the inferior portion of the maxillary sinuses, uni or bilaterally, and the patient complains of some symptoms, either go up higher if you can change your field of view and satisfy yourself that, oh yes, the ostium could be blocked, or just refer it to your local otolaryngologist. I mean, that should be a member of your referral family. Everybody listening to this should have, you can get their names through the primary care provider of the patient. You can say, to their doc, do you know a good ENT doc in the area, or one of the oral maxillofacial surgeons in your area, and just put them in your repertoire for referral. I've got an endodontist, Tom McClammy, who's a good friend of mine, who now he probably sends 5 cases a month to another clinician, Tim Hagan. Tim has a cone beam CT machine in his ENT office, okay? And he lectures to his ENT colleagues on dental things that, that he sees in the maxillary sinus and elsewhere. And they love to get that kind of referral where the dentist has recognized this could potentially be a problem in my implant case, and get that under control first. If there's a lot of paranasal sinus mucosal change, they'll put them on steroids, shrink things down, re-image or scope them, and determine whether or not things are coming under control. If it's real bad and it's the maxillary sinuses and you're wanting to put something up there, they may be a candidate for FES, functional endoscopic sinus surgery. And they just go up with a scope through the ostium, got a nice bright light on it, look inside the sinus, say, yeah, this has to be cleaned out. They might even do a little sinuplasty, where they use a little balloon thing to open the ostium. They suck out the contents, they put them on medications to help them heal, and that's a better implant candidate once that's under control. So yeah, ENT people will love you. And I've had a lot of ENT people that I've talked to that I'll say, well, dentists do sinus lifts in place, and they go, I don't think you should ever violate that Schneiderian membrane. Remember that Schneiderian membrane? They say you're just asking for trouble. They can't predict who and what, but they're not fans necessarily of sinus lifts. I hope that doesn't rub a bunch of people the wrong way out there, but I think we all need to take a good hard look at how we manage the patient that has paranasal sinus disease, and one of it is to have a good expert to refer to when you need it.
Perfect, thank you. Do you have another question on patients' overall health? Specifically, one came in earlier about utilizing CBCT in conjunction with the diabetes blood test that you were talking about. Are you finding any certain percentage of patients with diabetes that are showing the calcifications or the MAC?
Funny you should ask. Okay. I'm actually doing a presentation for Cigna in about a week's time. And one of the things that Bob Jenko's study, he found such a high percentage. This was 2 years ago, I started phoning back some of the clinicians that were what I call my heavier refers. Okay, so we did a little study. I found sequentially in one guy's practice 374 scans, probably 17 or 19 in the three, and they weren't all full scans, but we found I think it was 19 patients that had MAC. So I made up a little table. I sent it to his office, emailed it, and I said, can you tell me whether the patient has diabetes, hypertension, high blood pressure, or coronary heart disease, some type of cardiac problem because of the comorbidities of those things? And we actually found of the 19 patients, 11 had either plaques or MACs. Only 2 or 3 were diabetic. The others did not get sent. My follow-up, I never got anything back from Eric, the guy that I was sending it to. He never got anything back from the primary care provider when we asked them to look into potential diabetes. So it's out there. We just don't know the level of it. I've got some research that we're going to start with Penn, with some of their radiology and their young radiology folks, because they have a big cohort of patients that they've already done scans on. So they're going to go through and look for these calcifications. Then they're going to quantitate it. Then they're going to do prospectively. They're going to say, okay, when we scan for this, that, or the other, and we see these, we're going to send them, or we're going to do a hemoglobin A1C, and we're going to see the percentages. But I'm telling you right now, the ones that I have a sleep doc here in Phoenix, the last 4 patients that we sent that said that they should have hemoglobin A1C, 2 of the 4 came back right borderline for pre-diabetes. Well, isn't that when you want to catch it? You would rather get entry into the treatment modalities for diabetics early than late, okay, even if it's just changing diet and doing the other things. But I'm sure that when we all start looking for these things and start sending them off, that's going to be a pretty high percentage, because there's 80+ million unknown pre-diabetic patients out there. Well, how many of those were ones that we had in our dental offices that didn't have a diagnosis and ended up having periodontal disease that wouldn't respond properly? So the periodontists are all over this right now, but we're playing catch up, and we have a good tool to actually say, when you see this, do this, and then refer them for this. Hope that answered the question.
Definitely. We are really out of time. I'm going to do one more question, and then we will wrap this up real quick along these lines of overall patient health. if a patient, is a smoker or diabetic or has other overall health problems, and you're wanting to place implants, I guess what are the next steps, or what do you do? Do you tell them no? What do you do differently? Do we have to get their health under control before we can place those implants?
Without you can't proscribe anything, and you have to have protocols in your office for how you're going to treat and manage those patients. But I think you need to get a patient that's the healthiest they can be given the information that you can provide to them. So if you need to postpone implants until whatever diagnoses you're considering or whatever problems they have, maybe minus smoke cessation, because that's such a tough thing to have go, and we know smoking can impact the implant health. I think you just get them healthy as you can, say this is the way we'd like to do it. If we have your periodontium in good shape, if you've tested out and you don't have diabetes now, where you kind of need to watch your weight and other things, then you give them the option. I mean, it's kind of like the mask thing. I think you should give people the freedom to make their own decision given the information. So informed consent, tell them potentially here are the things that might happen to your implant if you don't do these things to improve your health. If you want me to do them, you'll have to sign this and say that you're willing to have me place an implant while you're not under control with your diabetes. I don't think many patients would sign that, but you need to think about the overall health. Dental, if you don't have your oral health, you don't have health. I mean, come on, it's the same thing we've heard from the Surgeon Generals for years now. I know I didn't answer that question very well, but that's the answer I'm stuck with. Okay.
It does seem to be somewhat situational, if you will.
Absolutely. Absolutely.
Well, Dr. Miles, I want to thank you for your time today. I want to thank everyone who joined us. Couple things. We do get education, gets a lot of questions on how do I learn about cone beam? What am I looking at? And one great reference on your website and through the Apple Store is Scanatomy. Scroll through, identifying axial, coronal, sagittal, an app on your phone or on your iPad that really will educate all of us and has very easy access on there. So just want to give you that plug for that, your Scanatomy there. And thanks again for presenting, everyone, for joining the CEs. We will be emailing you your CE certificates. Look for a email after this tomorrow about this time. You'll get an email with Dr. Dale Miles' information and some more information about what the education team is providing coming up. We have our Fast Track Friday events. We're learning more about the Vatech software. Doctor, you had mentioned the MIP and doing that slab rendering and showing different harder tissues. Eventually we'll wrestle you down and be able to sit down with you and train you on some of the software, show you a little bit more of our software there. But these Fast Track Fridays are really to get everybody in your office understanding what we're seeing and using this technology to be able to convey the message to our patients and improve their dental health. And then building on what we just talked about, this guided surgery, next month, Wednesday, April 7th, we're going to be pushing a little bit later. It's going to be at 7 Eastern. We're going to start our guided implant surgery series where we're going to go through guides with a single case. What do we need? What are the processes of planning this? Multiple in May and then full arch in June. So from the Vatech education team, and all of us here at Vatech. Thank you, Dr. Miles, again for joining us. Everyone who took the time out of their evening to join us, thanks again. And we hope to see everybody in the coming weeks for our Fast Track Friday series or in the future for our Key Opinion Leader series. Thanks again.
Thank you.